Felt fine, that is how the story almost always starts. He felt fine. He was working, exercising occasionally, eating reasonably well, nothing dramatic, nothing alarming a few years back. A doctor mentioned his blood pressure was a little high, somewhere around 140/90. But there was no pain, no dizziness, no sign of anything wrong. He was busy, he forgot to follow up. Life continued. A decade passed, and then on a Tuesday morning something broke. That is not a dramatic retelling. That is the clinical pattern. Quiet years followed by a sudden, irreversible event. And the reason it plays out that way, the reason a decade can pass with nothing visible on the surface while serious damage accumulates underneath, is the same reason most people never take that first blood pressure reading seriously. High blood pressure does not hurt. That is the whole problem, and that is what this video is about. Let us start with what the numbers actually mean. When a blood pressure reading says 140/90, it is measuring force, specifically, the force your blood exerts against the walls of your arteries with every heartbeat. The top number, 140, is the pressure during a contraction. The bottom number, 90, is the pressure between beats. When the heart is at rest, think of your arteries as a garden hose. Turn the water on at normal pressure, and the hose handles it without any problem. Now imagine running that same hose at twice the pressure, every minute of every day. For years, the hose would show wear, the walls would weaken, small cracks would form. That is not a metaphor. That is roughly what sustained high pressure does to the inner lining of your arteries. That inner lining has a name. Endothelium, it is one cell thick. Under normal conditions, it is smooth, flexible, and actively protective. It releases compounds that prevent clotting, keep inflammation low, and keep the artery walls pliable under sustained pressure. Those cells become stressed. They start to malfunction. The surface becomes rougher, stickier, more prone to inflammation. That dysfunction is quiet. It produces no sensation. But it is the beginning of everything that comes later, year 1, year 2, year 3. If you could look inside a person with untreated high blood pressure during the first few years, you would not see disaster. You would see the beginning of compensation. The endothelial dysfunction starts to allow small amounts of LDL cholesterol to penetrate the arterial wall. Immune cells respond. A low-grade inflammatory process begins. Fatty streaks, the earliest stage of atherosclerotic plaque, start to form in the walls of arteries, not yet large enough to obstruct blood flow. Present and growing at the same time, the heart responds to the increased workload by adapting. It is a muscle. When a muscle works harder, it gets larger. The left ventricle, the main pumping chamber, begins to thicken. This is called left ventricular hypertrophy. In the short term, it allows the heart to maintain output despite the higher resistance in the vessels. Your blood pressure may still read the same. You still feel nothing elsewhere. The small arteries throughout your body, called arterioles, begin to stiffen. Normally, arterioles can dilate and contract to regulate blood flow to different tissues. As their walls thicken in response to the sustained pressure, they lose some of that flexibility. The system becomes less adaptive. Your body is compensating, and it is remarkably good at compensating. That is the cruelest part of this disease. The mechanisms your body uses to handle elevated pressure work so effectively in the early years that there is nothing to feel, nothing to notice. If no one happens to check the numbers, nothing to prompt any action at all, year 4, year 5, year 6. At some point during the middle years, the heart's adaptation begins to work against it. The thickened left ventricular wall, which grew to handle the pressure, has now become stiffer. A stiffer ventricle has more trouble relaxing between beats to fill with blood. The filling phase of the cardiac cycle, called diastole, becomes impaired. The heart pumps adequately on paper, but it is operating with less reserve. It can handle resting conditions. It struggles more when demands increase. You might notice something during this phase, if you were paying close attention. A slight shortness of breath climbing stairs that did not used to be there. A fatigue after physical effort that takes a little longer to clear. These signals are easy to attribute to age, to poor sleep, to being out of shape. They are rarely alarming enough to send someone to a doctor, and they come and go, which makes them even easier to dismiss. Meanwhile, the plaques that began forming in years 1 through 3 have continued to grow. Some arteries now have narrowing, not enough to cut off blood flow entirely, but enough to reduce the margin for error. If one of those plaques develops an unstable surface, a crack, the clotting cascade can be triggered. That outcome is still some distance away, but the infrastructure for it is being built. There is also something happening in the small vessels, capillaries and arterioles that supply organs. They are thickening. Their internal diameter is shrinking. The tissues they feed receive slightly less blood flow than they should. Most organs tolerate this reduction quietly. For a while, the heart does, the brain does, the kidneys do. But tolerance has limits, year 7, year 8, year 9. This is the phase the modelagem calls very strong, and it deserves that description. The brain is extraordinarily sensitive to changes in blood flow. It receives approximately 20% of the heart's output despite representing only about 2% of body weight. It operates on an extremely narrow margin. Oxygen delivery must be continuous, precise, and stable under sustained high blood pressure. Two things happen to the brain's vasculature. The larger arteries feeding the brain develop the same plaques and stiffness as the coronary arteries, but the smaller vessels deep inside the brain, the penetrating arteries that supply the white matter and deep structures, are particularly vulnerable to high pressure. They can develop tiny areas of damage, small vessel occlusions, microinfarcts. Here is what a microinfarct is: a microscopic area of brain tissue that loses its blood supply and dies. Not a stroke that a person collapses from, not something visible on a casual scan. A tiny, silent loss of brain cells in the deep white matter, the tissue that connects different brain regions and coordinates their communication. One microinfarct changes nothing noticeable, 5 do not either. But over years, the accumulated loss of white matter begins to affect the speed and efficiency of cognitive processing. Memory retrieval slows slightly, processing speed drops, the risk of vascular dementia, a form of cognitive decline driven by accumulated vascular injury rather than the amyloid plaques of Alzheimer's, rises significantly. By the time someone notices the cognitive changes, they have usually been accumulating for years. At the same time, the kidneys are quietly deteriorating. The kidneys filter roughly 180 liters of blood per day. Filtering happens through tiny structures called glomeruli, clusters of capillaries so small and delicate that they are exquisitely sensitive to the pressures they receive. Under sustained high blood pressure, those capillary clusters are damaged. The filtration membrane becomes leaky. Proteins that should stay in the blood begin to appear in the urine. This is called proteinuria, and it is one of the earliest detectable signs of hypertensive kidney damage. As glomeruli are damaged, kidney compensates by increasing pressure in the remaining ones to maintain overall filtration. This accelerates the damage to the healthy glomeruli. A cycle begins. Kidney function falls slowly, measurably, but rarely in a way that produces symptoms until it is significantly impaired. Neither organ sends you a bill until the account is nearly empty. Year 10. This is the chapter the story has been building toward. Not because it is inevitable, it is not, but because, without intervention, this is where the decade of silent damage converges into something acute. There are 3 likely events, and they are worth understanding clearly. The first is an ischemic stroke over 10 years. The carotid arteries and the cerebral vessels have accumulated plaque. One of those plaques ruptures. A clot forms. That clot travels to a cerebral artery and blocks it. The tissue downstream stops receiving oxygen. Within minutes, neurons begin to die at a rate of approximately 1.9 million cells per minute in an untreated large vessel stroke. The damage is permanent unless flow is restored very quickly. The second possibility is an intracerebral hemorrhage, a brain bleed. The small penetrating arteries deep in the brain, weakened by years of sustained high pressure, can rupture under a sudden spike. The blood that escapes compresses surrounding brain tissue. This type of stroke carries a higher mortality than the ischemic type and tends to have worse neurological outcome. Blood pressure is the dominant modifiable risk factor for this event. The third is a myocardial infarction. The coronary arteries, already narrowed by plaque built up over a decade, experience a rupture in one of those plaques. The body's clotting response treats it as an injury and sends platelets and clotting factors to seal it. But the clot that forms inside a coronary artery does not seal a wound. It blocks blood flow to the heart muscle. The affected area of the myocardium begins to die within minutes. The outcome depends on how quickly flow is restored. There is also a fourth trajectory. Heart failure, the left ventricle, stiffened and enlarged over a decade of excess workload, reaches a point where it can no longer maintain adequate output. Fluid accumulates, breathlessness and fatigue become constant rather than occasional. The foundation was laid in years 1 through 9. The final chapter just makes it visible. Let us talk about numbers for a moment, not to frighten, but to ground this in scale. Research consistently shows that for every 20 mmHg increase in systolic blood pressure above normal, the risk of major cardiovascular events roughly doubles. That is not a linear increase, it compounds. A reading of 140 carries meaningfully more risk than 120. A reading of 160 carries dramatically more. And the risk accumulates over time, not just at the moment of measurement. Guidelines from the American Heart Association and the American College of Cardiology define high blood pressure as 130/80 or above, a threshold that reflects the evidence that damage begins well before the older cutoff of 140/90. The goal for most adults with hypertension is to stay below 130/80, though the specific target depends on individual factors including age, kidney function, and other conditions. These numbers matter because small differences in blood pressure, maintained over years, translate into very large differences in outcomes. Managing blood pressure to 130 instead of 150 is not a minor adjustment. Over a decade, it is the difference between the timeline described in this video and a substantially different one. Now for the question that probably feels uncomfortable: why do people ignore it? Not because they are reckless, not because they do not care about their health. The answer is both simpler and more interesting than that. High blood pressure is asymptomatic. The human brain is wired to respond to signals, pain, breathlessness, visible symptoms. What it is not wired to respond to is the absence of a signal. When there is nothing to feel, there is nothing to motivate action. This is not a character flaw. It is how human perception works. Layered on top of that is something called social normalization. When everyone around you has blood pressure in a similar range, a little high starts to feel like a variation of normal rather than a departure from it. Your father had high blood pressure. Your uncle did too. They were both fine for years. The cultural message is, this is manageable, this is common, this is not urgent. Then there is the medication question. A significant number of people resist blood pressure treatment not because they doubt its effectiveness, but because they do not want to be on a medication for the rest of their lives. They would rather try lifestyle changes first. That instinct is not wrong. Lifestyle changes are genuinely effective, and they are the appropriate first step for many people. The resistance sometimes translates into doing neither the lifestyle change nor the medication, while the years continue to pass. And finally, there is the gap between how blood pressure sounds and how serious it actually is. Slightly elevated sounds mild. 130/85 sounds like a number, not a threat. The language of blood pressure does not convey urgency. It is abstract in a way that chest pain or shortness of breath never is. That gap between what the numbers mean and what they feel like is where a decade of silent damage lies. On the question of medication is worth being direct. The evidence for blood pressure treatment is among the strongest in all of preventive medicine. Decades of large randomized controlled trials show that lowering blood pressure reduces the risk of stroke by approximately 35 to 40%, and the risk of heart attack by approximately 20 to 25%. These are not small effects. They represent millions of events prevented. Different drug classes work through different mechanisms. Some relax blood vessels, some reduce fluid volume, some slow the heart's workload. The right choice depends on the individual, and that decision belongs with a doctor. It is not about the number on the monitor. It is about the cumulative load on the endothelium, the heart, the brain, and the kidneys. Day after day, year after year, every week that blood pressure remains controlled is a week less of that cumulative damage. The benefit is not dramatic and immediate. It is the quiet accumulation of undamaged tissue over time, and medication is not the only answer. It is one answer, appropriate for many people, not all. What could have changed the trajectory? Every lifestyle factor that affects blood pressure works through a biological mechanism, not through vague wellness logic, but through specific, measurable pathways. Excess body weight increases blood pressure partly through a hormonal mechanism. Adipose tissue, particularly visceral fat, promotes a chronic low-grade inflammatory state and activates the renin-angiotensin-aldosterone system, the same hormonal cascade that antihypertensive medications often target. Losing even 5 to 10% of body weight can produce meaningful reductions in blood pressure in overweight individuals. Dietary sodium directly affects blood volume. When sodium intake is high, kidneys retain more water to keep the salt concentration stable. More volume in the circulatory system means more pressure. Reducing sodium intake produces a measurable reduction in blood pressure for many people, particularly those who are salt-sensitive. Aerobic exercise improves endothelial function, stimulating the release of nitric oxide, the same compound healthy endothelium uses naturally to keep arteries relaxed. Regular aerobic activity lowers resting blood pressure, particularly the systolic number over time. Sleep matters more than most people realize. During deep sleep, blood pressure normally drops by 10 to 20%. What researchers call nocturnal dipping. People who sleep poorly or who have untreated sleep apnea lose this dipping pattern. The sympathetic nervous system stays activated. Cortisol stays elevated. Blood pressure stays high through the night, when it should be recovering. Alcohol at regular and heavy intake is a meaningful contributor to sustained hypertension through sympathetic activation and cortisol interference. None of these changes requires a dramatic transformation, but they require consistency, the same consistency that blood pressure damage accumulates with. The biology works in both directions. Regular measurement is the first and most practical step. Blood pressure does not announce itself. It has to be checked. For most adults over 40, checking blood pressure at least once a year, more often if it has been elevated before, is a reasonable minimum. If the numbers are elevated, the conversation with a doctor can begin with lifestyle, with monitoring, with context, but the conversation has to start. High blood pressure does not explode, it erodes. And erosion only becomes visible when something breaks. If you are watching this and you cannot remember the last time your blood pressure was checked, that is your answer about what to do next, not tomorrow. When you feel something, the feeling is not coming. That is the whole point. This video is for educational purposes only. It is not medical advice and does not replace a consultation with your doctor or cardiologist. Do not start or stop any medication based on this video. Blood pressure management is highly individual. The appropriate target, the right treatment, and the timing of intervention depend on your full medical history. which only a qualified clinician can assess. If your blood pressure has been elevated, talk to a healthcare professional.